Yes, okay, great. So what we have today is a different thing. We're not going to be going over a theme. So if you want to put anything in the chat room or your diagnoses, you're more than welcome to do that. If you just kind of want to listen in and hear what we're going to talk about. We've got about 10 interesting cases. We'll go for the next hour. And these are more sort of unknowns, if you will. So these are not related to any lecture or anything like that that the UT Southwestern residents have been getting with Dr. Vandergriff. They're really just more interesting cases. So and each one of these has got some really good teaching points on it. So I hope it's educational for you. So the first biopsy, notice it's a beautiful, deep, probably 6 millimeter punch biopsy. And that's exactly what we like people to do. For inflammatory skin disease, and a lot of people are doing shave biopsies of inflammatory skin diseases, but I really strongly encourage you not to get into that bad habit of shaving inflammatory skin diseases. We can't give you good information, really. We can give you some information, but we can't give you complete information. And just put yourself in the shoes of a patient. You know, if they, have a skin disease, they want to just have one biopsy. They don't want to get 2 office visits, 2 anesthesias, 2 painful, procedures and this, that, and the other. They would just like to get one biopsy, one answer. So the best way to do that is to take the most classic lesion that you can take, the most classic stage of its evolution, and take a good deep biopsy that allows us to evaluate the superficial and deep infiltrate, not just a shave, because that only lets you look at the superficial part. If you're biopsying a paniculitis like this, a shave is worthless, totally worthless. If you're biopsying an alopecia, shave's worthless. If you're biopsying most inflammatory diseases, it's pretty much worthless. So please, I implore you, don't do that. So anybody that's going to ever be in our residency program, once we get approved, hopefully, unfortunately, it's going to be drilled into their head, and when they leave the program, they're going to have scars because I'm not going to allow our residents ever to take shave biopsies of inflammatory skin disease. So just do not do it. This is an example of a paniculitis. And paniculitis is really, it's best to make your diagnosis of paniculitis. You want to hang around at low power more than go straight to high power. So we always talk about low power diagnosis, high power mind. Well, you really need to do that when you're dealing with the paniculitis, because the first thing you're going to ask yourself is it involving mostly the lobules, mostly the septa, or is it a combination of those? So these criteria that we apply, they're very logical, very well thought out. They really are kind of like a mathematical algorithm. I don't think like a computer algorithm that basically kind of figures out if you like to, watch certain TV shows and then Netflix tells you what's coming on. But it's more like if you progress through these things in a systematic fashion, you can make an accurate diagnosis the majority of the time. So we look at this, we say, well, is it mostly lobular? Is it mostly septal? And it's mostly lobular, especially this side. You got septal involvement here too, but mostly the lobules, almost all of this lobule over here is gone, inflamed. Is there vasculitis or not? We ask ourselves that. And then you may have to go to higher magnification to assess that. But then we want to ask ourselves what kind of inflammatory infiltrate is present. And then is there any other ancillary features? Is there degeneration of the subcutaneous fat, for example? Is there mummification? Is there calcification? Is there this sort of mummification of the fat like you can see with pancreatic paniculitis? Is there sort of what looks like somebody took scissors and dissected along the little borders between the lobules and the septa like you see with alpha-1 antitrypsin deficiency paniculitis? And then is there anything in the dermis overlying? So you say, okay, it looks like it's a paniculitis, but is it also paniculitis and a dermatitis? So those are all the things we want to ask. And then as we go to higher magnification, we want to apply those various things. And as we go to higher magnification, you can see even at low, you say, well, these are probably going to be mostly lymphocytes because they're dark and black. And sure enough, we go to higher magnification. Yes, they almost all are lymphocytes here. Notice that there's also this pink homogenized fibrin-like change to the fat, it's hyalinized. That's important. We see that in a relatively few number of diseases. And then there is some septal involvement. It's relatively minimal. Really, it's mostly just this lobular involvement that's just kind of impinging upon the septa here. So it's a lobular, mostly paniculitis, and there's no vasculitis at all. We'll look at this other piece over here, which kind of shows the same thing, just a little more inflammation here. So mostly lymphocytes with some plasma cells, lobular with fat degeneration. The number one thing I would really want you to think about here would be lupus erythematosus profundis, LE paniculitis. And here you see that mummified fat that's just turned to this hyaline-like material. And you can imagine if you were to palpate somebody's skin where their fat had turned to this, pink, firm, fibrant, mummified material, it's going to feel like a block of wood. And so some paniculitis, it feels kind of rubbery. Maybe some it feels almost atrophic. Maybe some feels like nodules, like erythema nodosum. But when you feel this, it feels like you're feeling like just something extremely firm and woody. And that's classic for lupus paniculitis. And then if you look at the overlying dermis, there's also a inflammatory infiltrate up here in the dermis. You got the lymphocytic infiltrate of the dermis with some mucin, which is what we see if we were to do a superficial biopsy, not even get down to the fat. That would look more like garden variety lupus erythematosus, like a lymphocytic infiltrate of tumid LE. And then if you look at the DE junction, and probably about 50 to 60% of biopsies of tumid LE have overlying features of discoid LE. And you've got the thickening of the basal membrane zone here, smudging with melanophages. You've got some edema and sclerosis of the papillary dermis. Those are all classic features of overlying discoid LE. So this is a beautiful example of LE profundis. Okay, this other side also. This one's got a follicular plug in here of the overlying discoid LE. Now, why do you see discoid LE in lupus profundis commonly? Well, number one, interestingly enough, it's the most common form of paniculitis in the upper part of the body. The arms, the face. You'll biopsy people that have discoid LE of the scalp. If you get a deep enough biopsy, you'll often see some evidence of subcutaneous involvement there as well. So LE profundis is the most common paniculitis of the face. So if you look at the next slide, I've got a couple of clinical pictures. So you can imagine you feel this person's face, what that's going to feel like. It'll feel like a, woody, indurated. Very, very characteristic of LE profundis there. And then this is one on the leg here, upper leg, not bottom leg, not the calf or the pretibial area like you see with erythema nodosum. So anyway, lupus profundis. So classic, beautiful example, lobular, mostly paniculitis. The most important thing to put in the differential diagnosis here is one of the variants of the subcutaneous paniculitis like T-cell lymphomas. And we have two types of that. We've got the alpha beta type and we've got the gamma delta type, which is a much more aggressive, more dangerous type of lymphoma. But even those don't give you the subcutaneous fat involvement, they do not usually give you that hyaline sclerotic change of the lipocytes. So you can tell those apart, in my opinion, most of the time. So that's a beautiful example of lupus profundis, lupus paniculitis. Okay, let's take a look at this one here. And we've got a punch biopsy. And the reason I like to show this is not that it's so difficult to diagnose histologically, but that it's often a clinical misdiagnosis. So we've got this, something's going on in the dermis, obviously, right? So is it inflammatory? Is it neoplastic? It's got this kind of crack artifact here. And that's because basically the cell types often fall apart from one another. And so when you actually make a slide of it, basically it's just discohesive. So what kind of cells are these? Well, low power, all we can kind of say is they're sort of purple. Is it an inflammatory or a neoplastic process? Well, it's hard to be sure, but we say, well, if it's a neoplasm, is it going to be benign or malignant? Well, it's a small round nodule in the dermis. It looks relatively symmetrical, so it's going to favor benign, just looking at that. Is it going to be epithelial or non-epithelial? Kind of hard to see here at this power. So let's go to higher magnification and see if we can kind of tell what sort of cells they are. And now, as we get to higher magnification, you can see that these cells have kind of an angulated, almost spindle cell, plus this sort of cuboidal morphology with all this dark brown material in it. What is that dark brown material? And that's one of the sort of unfortunate things about the computer, is that you can't, like with a microscope, you can actually take the substage condenser and rack it down, and you can see if this stuff will actually is refractile when you look at it. And if it is refractile, it's because it's a crystalline material and it's refracting light, and that favors the diagnosis of something like hemocytoratic. So if it's refractile and it's brownish like this, golden brown, that's hemocytoratic. Can't really tell that under the microscope, but looking at this, you'd say, well, maybe it's melanin, maybe it is hemocytoratic. This looks a little bit more brownish than black. Melanin is black. It can be brown if it's not quite as concentrated, but we favor this being hemocytoratic. And then you've got all these other cells here that have got these sort of angulated morphology. There's some blood vessels, intersposed with this as well. So this was probably sent in as rule out malignant melanoma. So it was thought, oh my gosh, it's black, it's in the dermis, it's gonna, person's probably got melanoma, so let's take a biopsy of it, we'll know, but it's not melanoma. This is an example of a hemocytoratic variant of dermatofibroma, cellular dermatofibroma, and there's a lot of different variants of dermatofibroma, but this is one that we see not uncommonly, where you get a lot of hemosiderin that gets deposited in there, and that's because you also get a lot of extravasated erythrocytes, and then when they get reabsorbed and whatnot, the hemosiderin stays around. And so that's why you've got all the hemosiderin. These are some nice examples of the so-called keloidal collagen bundles that are present at the periphery of a dermatofibroma. And that's a helpful clue to the diagnosis. It's not a definitive criterion for diagnosis. You can get dermatofibromas that have 0 keloidal collagen bundles, but they're present quite commonly. And some people refer to this as the so-called donut sign. A couple of things you can sometimes see overlying a DF is some epidermal hyperplasia. You can sometimes get some little basaloid proliferations there that can look like a basal cell, but that's usually when the dermatofibroma is more superficially situated. This one's a little deeper, so it's got no epidermal involvement. And these kind of larger lesions that are more cellular, that can have a lot of extravasated erythrocytes in them, almost even called an aneurysmal dermatofibroma. They're often seen around the ankle, the lower part of the leg, and some people actually refer to that as the so-called ankle type of dermatofibroma. So anyway, that's an example of a cellular hemocytoratic dermatofibroma. They often look a little darker. They often are usually sent in as something as a pigmented lesion, simulate nevus and melanoma sometimes. So just remember this entity. It's totally benign. One other kind of thing I'll mention is that everybody there's certain reflexes that get inculcated in teaching dermatology. And some of them are good reflexes, and some of them are not so good reflexes. Some of them are based maybe sometimes just on a name. And, for example, people say, well, dermatofibroma, we have to always rule out dermatofibrosarcoma protuberans. Well, you really don't have to always rule out dermatofibrosarcoma protuberans. The vast majority of dermatofibromas don't look one single thing like DFSP. We would never be concerned with DFSP looking at this variant of dermatofibroma here. We would never order a special stain. We would never be worried about CD34. We would never worry about that. Where we do worry sometimes is when you see a myxoid variant of a DFSP that can simulate a neurofibroma. And if you do one of these shave biopsies of a large soft tissue plaque that looks like a soft tissue tumor, and you just send us a superficial shave, sometimes you'll get that myxoid variant that can look like a neurofibroma, and then you get a misdiagnosis, and then the lesion sits around another couple of years and gets into the brachial plexus or causes problems, and then somebody finally takes an incisional biopsy and it shows a storiform pattern, and then the lawyers start calling. So again, beware of taking superficial biopsies of large lesions. Get us a larger, deeper incisional biopsy, something like that. We're not asking you to stop your clinic and excise every potential thing that could possibly be a melanoma that's got a 1 in 100 chance of it. But we are asking you, if you get something that's weird, don't just take a superficial shave. Okay, that's another thing that unfortunately has poisoned the well for dermatology. They pretty much 99% of dermatologists do shaves on everything. You really need to take an incisional biopsy when you're dealing with a soft tissue potential problem, or lawsuits can develop. And nobody likes to be in the courthouse. I'd rather be seeing patients or being with their family or something like that than getting sued. Okay, this is a rare tumor here, something that's unusual. So it's nice to see some of these unusual things that you will pop up with. So at low magnification, pretty much all we can say is that it doesn't look like there's much of anything here. So when you see that, you start thinking, is it inflammatory? Is it a neoplastic process? If it's a neoplasm, well, it's going to have to be something like in collagen or something like that. What part of the body are on? Well, some hair-bearing area where there's some sebaceous glands. But that's about all we can really say here. Epidermis looks normal. Maybe it's probably from somewhere, maybe like an extremity that's got pretty thick collagen. Well, let's go to the dermis and see if we see anything down there, because notice the epidermis is normal. Obviously here if you're looking at it blind, which we always recommend that you do, by the way, don't go to the history first. Always look at it without any information, because then you're biased and then you can't put the genie back in the bottle. So look and see, well, is there anything in the epidermis? Maybe it's tenuversicolor. Well, we'll look here real fast. No, there's nothing. Does it look like maybe there's a little bit of a macular type keratose, a little budding? Maybe, depending on what the clinical is here. Could it be some of the reticulated epidermal pigmentary disorders like CARP or something like that? Maybe, but that's all just with no information. So let's look down at the dermis. And there's something going on down here that's a little different. There are these large cells that are hyperchromatic. That's not normal. So maybe it's a neoplastic process. Okay, so they punched into a neoplasm, which is okay if they didn't know what it was. Maybe it looked kind of reddish and they thought it was inflammatory and turned out to not be inflammatory, turned out to be a neoplasm. But let's take a look and see what we've got here. We've got these cells that have multiple nuclei in there. This almost looks like a little histiocyte in a way. We've got other cells that are more dark, staining, pleomorphic. We've got some blood vessels here. So some neoplasms were named by people that were logical. They said, well, let's give it a name that makes sense. And so there's multinucleate cells. We're not sure exactly what cells they are, but maybe they're fibroblasts, maybe they're histiocytes. There are blood vessels, so we call it angio. They're cells, sure they're cells. And then they look like histiocytes in a way. It kind of looks a little bit like a so-called histiocytoma, which another name for histiocytoma, dermatofibroma. So the name for this is multinucleate cell angiohistiocytoma. It's an interesting rare entity. If you're going to learn about this entity, you need to be able to recognize these kind of cells. They have these little multiple nuclei in them. They're admixed with cells that have kind of a spindle cell and angulated morphology, sort of like the dermatofibroma a little bit. Then we've got the blood vessels in there. So that's why we call it a multinucleate cell angiohistiocytoma. And histiocyte just means a cell that's kind of like a monocyte macrophage that's living in the skin and the tissue. So that's basically what this lesion is. It's a rare bird. We don't see this very frequently, but it's an interesting lesion that at least you now know about. And these lesions present in a couple of different ways. They can present as a solitary lesion that kind of looks like an angioma, like here, or they can present as these little multiple sort of agglutinated brown papules. This is probably the more common pattern that we see. They're often on the leg. They're often seen in middle-aged or younger women. They can be seen in men. For some reason, they seem to be more common in women. And then when you biopsy them, they show this pattern. So if you just saw something like this, clinically, you might think about possibly urticaria pigmentosa or something like that. And then indeed, that's often what these may be sent in as to us. But it's just an interesting variant of an unusual tumor that I doubt if a board exam is going to put this on. But at least you've now heard of it and you know about it. And if you do end up seeing it on the board examination, you'll know what it is. So clinically, it's going to kind of look like other forms of vascular neoplasms, multinucleate cell angiohistiocytoma. Now, some things are practical. Some things are just kind of we teach for the boards. Some things are esoteric like the last one. Now we're going to show you a more practical sort of case. And this is not something that you will encounter on the board examination. So you can relax and just learn on this, but you will not be, the one thing the board examination will not put on there is anything that's controversial. They don't want to get sued either. So they're going to put on there pretty straightforward things. They may be straightforward things with lots of detail that you need to drill down into and learn that they expect the dermatologist to know, but they're not going to put something on here that a dermatopathologist might argue or might send for special stains or genetic testing. So they're not going to put an atypical spitzoid melanocytic lesion on there, nothing like that. If they put a melanocytic lesion on, it's going to be an obvious dysplastic nevus. They might ask about the dysplastic nevus syndrome. They could put an obvious Spitz's nevus and maybe ask you about, the setting where that might occur the most commonly. They're going to put an obvious malignant melanoma on there to make sure that you're not a dangerous doctor, that you're going to be able to recognize it. So, but they're not going to put a lesion like this on. But I'm going to show it to you because it's important that you know and understand where the limitations are sometimes in what we do under the microscope. So we've got a punch biopsy or maybe even an excisional biopsy here of a lesion that's a melanocytic one. So low power, you see some nest, you see some pigment, you say, well, that looks melanocytic. Is it benign or malignant? So once you get in the melanocytic category, obviously there's two answers. It's either melanoma or it's not melanoma. Now, if it's melanoma, there are a lot of different sort of subtypes of melanoma, linear malignus, spreading melanoma, nodular melanoma, acro-lentiginous melanoma, all that sort of thing. But basically, the most important thing is melanoma or not melanoma. That's the most important. Is it benign or is it malignant? If it's nevus, there's a lot of different variants of that too. And we've learned about those and we'll continue to learn about those. But the most important thing is the ability to apply the criteria to decide whether it's benign or malignant. So we look at this one and say, well, is it broad? Well, this is probably an excisional biopsy that's probably around a centimeter. Most of it is in this area here. So it's not super broad, at least here. It's possible that there may be some involvement out here that we're not seeing at low magnification. So that could be a sign that it may be broader than it looks here. So we're going to maybe have to apply some other criteria. Is it symmetrical or not? Well, it doesn't look super asymmetrical at low power, but as we go to higher magnification, we may see some features that show that it's really not perfectly symmetrical. Is it well circumscribed? Those are the three most important things at low power. If you can't be sure about that, then you start relying on ancillary criteria. Are there mitotic figures? Is there maturation? Is there pagetoid spread? Is there a regular distribution of melanin? Is there necrosis? All of these are other things that we look at as we go to higher magnification. So let's go to higher magnification. What's the age of the patient? Well, this patient's old. You got a lot of sun damage. So when you see an atypical melanocytic lesion in an older individual, instantly you start being concerned about the possibility that you may be dealing with a malignant melanoma as opposed to a benign process. Now, obviously, older patients get nevi too. They get more nevi than melanoma, thank goodness. But still, you obviously want to be concerned because there's a greater chance of a lesion being a melanoma in an older person than in a younger individual. Younger individuals get melanomas also, but you want to make sure that you're not missing a melanoma if you're dealing with an older individual. And let's go to higher magnification. And now we've got some other ancillary criteria here that are cause for concern. We've got nests of melanocytes that coalesce. That's a sign of malignancy. If the nests are very well circumscribed and they don't tend to coalesce and they're very discrete, that's a sign of benign. Here they're coalescing and they're stuffing and filling the papillary dermis. That's a sign of malignancy. We've got pagetoid spread. We've got single melanocytes at the dermal junction and above it. We've got a lot of pagetoid spread over here. We've got involvement of this follicle, and we've got involvement of single melanocytes that go all the way down to the base of the follicle. Not just at the top here. That's okay. That's allowed. But when it goes all the way to the bottom, from the top all the way to the bottom, that's not a good sign. That's analogous to diffuse pagetoid spread throughout the epidermis, and it's a sign that you're dealing with melanoma in situ and it involves a follicle to that degree. So this case is challenging because it's a so-called nevoid malignant melanoma. It looks like a nevus in some areas. The cells are arranged in these nests. Some of the cells are almost epithelioid, but notice that there's different populations. These cells look different than these. That's a sign of asymmetry. You've got some cells that have abundant cytoplasm and abundant melanin in the cytoplasm. That's a sign of atypicality of melanocytes. And now you've got the poor circumscription. You've got this single melanocytic proliferation extending beyond the dermal component with pagetoid spread out here. So this lesion is not well circumscribed. It's not symmetrical. It's kind of pseudo-symmetrical, the low power, but it's not. It's actually not symmetrical. It's not well circumscribed. So this is an example of a malignant melanoma with features of a nevus in many ways. So you're not going to get this on the exam, but it's not all that hard to diagnose really. On a scale of 1 to 10 for, a dermatopathologist like me and others, it's going to be about a 1. It's not going to be 10 in difficulty. We would easily call this a melanoma, but it's got a few unusual features, and that's probably not what you're going to see on the exam. And that's one of the reasons we just want to show it to you, to realize that sometimes melanomas can look nevoid. Now, go back real quick. If you were to get a shave biopsy of just the nevoid component here, and again, beware of shaves. If you just had a shave of this area right here and just sample that alone, you might get a wrongful diagnosis, a misdiagnosis. Okay, so just remember, we want to take something that's going to be representative, and you're going to encounter melanomas that don't look like melanomas. Every day in this practice here, almost every single day, not every day, but probably 4 out of 5 days, we get a biopsy that turns out to be a melanoma that the clinician did not think was a melanoma. Sometimes it happens more than once in the same day. We just had a case yesterday of a lesion on the scalp of the relatively young woman that the clinician thought intradermal nevus or basal cell, 2 melanomas in the same area. One of them was probably metastasis. So melanoma will fool you. So you must be aware of it. I mean, this lesion, that almost looks like a seborrheic keratosis. That lesion also. So melanoma doesn't read the textbook. It will fool clinicians up to 30% of the time. So you can be fooled with melanoma. So you want to make sure that when you do get encounter a melanoma that looks weird, that your biopsy is going to catch it so that the dermatopathologist can make the diagnosis and we don't get a bad outcome, because that can cause all sorts of problems. If you look at a nevoid melanoma under the microscope, it looks, you just saw that, but if you look at it clinically, it can look exactly the same as any other type of melanoma. So just because it looks like a nevus under the microscope doesn't mean it may not look like an obvious melanoma clinically. Now, we often see melanoma arising in association with a pre-existing nevus. So those may look like a nevus and just have focal areas of melanoma rising in them, but most kind of quote nevoid melanomas look pretty much like other types of melanomas. Okay. Now let's shift gears again, and this is fair for the board here. Okay, so this is something the board very well might show you, and you should know this pattern. It's probably not one that a first-year resident's going to know yet. They might at the end of their first year. Second years, you should know this. Third years, you should definitely know this. So we've got a punch biopsy. We've got a sparse superficial paravascular dermatitis. Looks more like an inflammatory as opposed to a neoplastic process. The epidermis is not normal. At low magnification, you can see that it's thickened, it's acanthotic, it's psoriasiform, somewhat irregular. And then we also notice that it's pale at the top. Okay, that's very, very important to know that. So we know the 3 patterns that are most common for intraepidermal reaction patterns that we see. We get spongiosis, we get acantholysis, and then the third one is ballooning degeneration. Those are the 3 most common. There's about 10 others. Glycogenic acanthosis, focal acantholytic disc keratosis, we'll talk about, some things like that. But the 3 most common are those that when I want, it's always good to know the fundamentals. Like you're playing basketball, you know how to dribble and pass. You can shoot from outside the 3-point range too, but that's not the critical thing. You need to know how to do the fundamentals. The same thing is true here too. You need to know the basics, and then you can add the ornaments to the Christmas tree later on. So we've got something pale And notice where it's pale. And so when you think pallor, I want you to be thinking of ballooning immediately. And when you think of ballooning at the top of the epidermis, I want you to always think about nutritional deficiency disorders. So this is one of those A plus B plus C equals D. It's the right answer 99% of the time. Psoriasis hyperplasia, ballooning degeneration and pallor of the upper part of the epidermis with overlying parakeratosis. That equals nutritional deficiency until proven otherwise. Okay, so that's almost always the pattern. And this is classic. So this, if I were writing questions for the board, I used to do that. I would send something like this, because this is perfect. Shows you everything you need to know. It's not controversial. There's no difficulty in making a diagnosis. Anyone that knows anything about dermatopathology, that's been trained as a resident, should know this. And in fact, it's so obvious that you might even make a second order question out of it. You might say, which of the following conditions is most likely associated with this histologic pattern? And then maybe you throw in pellagra and, zinc deficiency, some of those things. You might say which one of them is not associated with it, and then throw all the deficiency diseases and then throw something else in there. Now, what else can do this? We always have to ask ourselves, is there anything else that can possibly give you this pattern? The only other things that sometimes can give you this kind of ballooning degeneration, not like this where you got pretty much normal epidermis beneath it and then the ballooning above it, is viral vesicular dermatitis, Coxsackie viruses. And those, you get intracellular, intranuclear inclusions, pink structures, which you don't see here. More inflammation in that too, in most cases also, with or without any epidermal involvement, and usually on the hand or the feet or the mouth where that's located. And then sometimes irritant reactions, outside in, somebody that's a mechanic and maybe they got gasoline on their hands or something like that. But that's not usually going to give you this nice, beautiful ballooning degeneration that stops right there. That's going to usually involve the entire thickness of the epidermis. And it doesn't give you this sort of nice zone of parakeratosis up here like you see here. So this is really almost pathognomonic of a deficiency disease. And they all look the same. So on the microscope, they pretty much all look the same. Necrolytic acral erythema, that actually can sometimes give you a little bit more interface dermatitis also and look a little bit like a combination of erythema multiforme and the ballooning degeneration. But if you get a really good classic case, it's going to look like this. Zinc deficiency, pellagra, they all look the same. Biotin responsive multiple carboxylase deficiency, they all have the same idea. The skin it doesn't get enough nutrients. So what's it doing? Well, it forms a ballooning degeneration at the top. It's like saying, hey, feed me, like Zeke Elliott. I need more nutrients here, and it's not getting it. So it forms this abnormal, crusty, flaky paint type of skin. And in pellagra, it's also photodistributed. So just remember those entities basically need to know what this thing looks like, and they all basically look the same. So that's a beautiful example of a pretty classic disorder, and that's absolutely, positively fair game for the board examination. This one also could be, let's see here. It's a little bit funky, this slide, but it actually is an interesting pattern. We've had several cases of this disorder just recently, but notice once again we're dealing with a nodular inflammatory disorder, okay? Once again, notice the beauty of the punch biopsy. Shave biopsy here is worthless. You're not gonna get a diagnosis. It's a waste of time, waste of money, waste of the patient's visit to you, waste of the insurance of the medical health care system. So a shave biopsy is a waste, and in dermatology, we try to, and in medicine, we should try to be decreasing waste instead of increasing waste. So don't shave inflammatory disease because we need to know the pattern here. And it is a nodular dermatitis, which is important. We talked about superficial paravascular, superficial and deep. We talked about nodular diffuse. Well, this is nodules. We've got all these little nodules of these dark staining cells, which are lymphocytes. And we're also going to see, if you look here, there's also some histiocytes in here. So it's a nodular dermatitis. Okay, beautiful example of that. So once again, we're dealing with these inflammatory skin diseases. We start asking ourselves, what's the predominant cell? Mostly lymphocytes. Is it lymphocytes and histiocytes? Are there any areas where histiocytes predominate? Is there any pattern to the nodularity of the infiltrate? Is it following neurovascular bundles? That's a helpful finding. If you get a granulomatous dermatitis, it's kind of going along nerves, you want to think about the possibility of Hansens disease. If it's nodular and it's also got maybe a band-like infiltrate superficially, a lichenoid plus nodular, you might want to think about syphilis, something along those lines. If it's purely lymphocytes just around blood vessels and it's nodular, that favors one of the lymphocytic infiltrates. We know there's about 8 or 9 of those. So as we go to higher magnification, you can see that a lot of these cells are pale, admixed with the lymphocytes, histiocytes here. So this is a lymphocytic and histiocytic infiltrate. And in some areas, and look, notice that it's kind of following these little neurovascular bundles here. In some areas, you've got histiocytes that predominate. Whenever there are zones where histiocytes predominate only, or they're present predominantly, that means that it's at least focally granulomatous inflammation. Okay, we all know that there are 5 main types of granulomatous inflammation. So this one would probably be closest to either maybe sarcoidal or tuberculoid. These are maybe epithelioid granulomas. Are not as tightly packed as the epithelioid granulomas we see in classic sarcoidosis. This also has got a lot of lymphocytes in here as well. So we might think about something like syphilis in a case like this, if there are a lot of plasma cells, which there really are not. We might think about something like Hansens disease. We might think about other kind of infections. We might think about maybe an individual with HIV infection that's possibly got some kind of weird infection going on here too. So you always want to ask yourself all these questions here. Here's a nerve, and notice this inflammation is really targeting right around this nerve twig here. So perineural inflammation, always think of Hansens disease. Oh, and it also happens in syphilis as well. Syphilis can do just about anything, but it actually can give you perineural inflammation. Herpes virus also can give you perineural inflammation. You can get a post-herpetic granulomatous dermatitis. I've never seen one look quite this diffuse and nodular before, but you certainly can get that. They usually also will give you some epidermal changes. And notice this pattern here. We've got a Grenz zone. Grenz, German word for frontier. So it's the area between the inflammation, and I guess this might be the little checkpoint up here or something, but there's a zone, a no man's land, if you will, between the epidermis and the inflammation and the dermis here. So basically, we've got a diffuse nodular granulomatous and lymphocytic infiltrate, and in this case, this was an example of Hansens disease. Now, this would probably, and the thing that's interesting about Hansens disease, and I recommend as a dermatologist, I strongly recommend that you take an interest in Hansens disease and learn about it. It is not a historical disease. We still see lots of cases. We saw one case just this morning, and 3 biopsies submitted. Each one was submitted as rule-out squamous cell carcinoma. It had a granulomatous dermatitis in there. We did a 5 stain on it. It was loaded with organisms. So you need to think about it. People get exposed to Hansens disease in many different ways. They can travel, or they can acquire it endogenously in their own backyard if they're messing around with armadillos. And a lot of people in rural areas, they capture armadillos, they butcher armadillos, they eat armadillo meat, and you can get Hansens disease from that. This type of Hansens histology has got granulomatous, plus it's got a lot of lymphocytes in there, so it's probably going to be more on the borderline category. And the nice thing about Hansens, it's really very logical because you can almost do a graph. The greater the amount of inflammation, the greater amount of host immune response in the disease, the fewer the number of organisms, and the more the granulomatous inflammation, the weaker the immune response, the greater the number of organisms. They get the foamy histiocytes without a lot of lymphocytic inflammation in there. And so this would be more kind of one that's not in the polar lepromatous stage. It's certainly not in the polar tuberculoid stage where you get very few organisms and little, just usually sarcoidal granulomas, a relatively limited number of granulomas in the infiltrate. This would be more of the borderline lepromatous form, which would probably be maybe somebody like this, where they've got a lot of organisms, a lot of lesions. They're asymmetrical distribution. Individual lesions kind of an asymmetrical pattern to them. And so that would be more probably borderline lepromatous. And if you do a fight stain on borderline lepromatous, it's got a lot of organisms in there still. It's still multi-bacillary disease, but it's not polar lepromatous. And then when you treat patients, sometimes you don't treat them. They can develop reactions to their disease. So Hansens is a fascinating thing, and as dermatologists, we're one of the specialties that takes care of these patients, so we really need to know about it. I've seen these diseases missed where the disease has been delayed in making the diagnosis, sometimes for years, because nobody thought about it. So you have to kind of have an index of suspicion, and if you see something that looks like this, you certainly would have to think about it. And it is something that we do see still today, not uncommon. We've had 3 cases in 1 month in our lab, so it's out there. And if you don't think about it, you're not going to make the diagnosis. Okay, here we've got another biopsy, and notice low power once again. Where's the pathology here? Where is the pathology? And if you did if you even did a punch, you're probably compromised in even reaching this biopsy. So a punch biopsy, if you do a good deep punch biopsy, kind of gets down to this area right here. Subcutaneous fat. So when you do a punch, unless you're doing it right over the radial artery or something like that, over the, carotid artery, pretty much you want to take a punch that just goes all the way down to the subcutaneous fat. Make sure you get deep enough and run it all the way down to the barrel of where the plastic and the metal hit. If you really want to get deeper in that, you got to go down beneath the plastic. You got to bury the plastic below the level of the skin. So this guy may have done a punch. If he did, got really deep because this pathology is below the level of the subcutis. So what lives below the subcutis? Well, the fascia. So if you get a biopsy of the fascia in dermatology, the good news is there's really very few diseases you have to think about. Is it a neoplasm involved in the fascia? Is it a sarcoma? Is it like DFSP that's dissected underneath the fascia? Well, maybe. But if it's a nodular lesion involving the fascia of the skin, you actually have a biopsy that gets that deep, you really only think of a few things, maybe an infection, maybe some kind of a weird ruptured cyst, but the most common thing is nodular fasciitis. Okay, so sometimes just like in a multiple choice exam, you can wipe out 3 or 4 of the answers and you're left with 1. Well, if you get a deep biopsy of the fascia of the skin, there's really probably only about 4 or 5 reasons that a dermatopathologist, dermatologist would ever biopsy the fascia. Nodular fasciitis, maybe you think it's a cyst or something like that, and it happens to be this. Maybe you're looking at eosinophilic fasciitis, Schulzmann syndrome, which is a thick bound down scleroderma-like process, nephrogenic fibrosing dermatitis, systemic fibrosis that actually can get into the fascia. So that might be another reason you biopsy. It's one of those kind of entities. And then maybe an infection, but there really aren't too many reasons that dermatologists get fascial biopsies or take fascial biopsies. Now, the surgeons do it all the time. Necrotizing fasciitis, they're worried about that. But here we've got a nodular proliferation of these spindle-shaped cells with a fibromucinous stroma. And probably the most important thing about this is that you don't want to get an overdiagnosis in something like this as a sarcoma. The other diagnosis, the other name for this is pseudosarcomatous fasciitis because it can look like a sarcoma. And basically the reason for that is that these cells proliferate, and whenever you get proliferating fibroblasts, you get mitotic figures, and they can look atypical sometimes and basically can simulate a neoplasm. So this is not a neoplastic process. It's really almost analogous to a dermatofibroma that's just basically occurring in the fascia. So this is an inflammatory disorder that's induced by trauma most commonly. And if you were to, when kids bump their head, for example, they get that swollen nodule on their forehead. If you actually go in and biopsy that after a couple of days, you'll often see features of nodular fasciitis. And sometimes it sort of proliferates and doesn't go away quickly enough. And that's when somebody takes a biopsy of it and it looks like this. And then here you see a lot more histiocytes. You can see it kind of looks like a dermatofibroma here in this field. In other areas, it looks more spindle, like over here. So, you get a late stage dermatofibroma, it becomes more spindle. Early on, it's got histiocytes and fibroblasts and extravasate erythrocytes. So it's really the same type of entity as a dermatofibroma, just sort of like what we saw before. It's benign, it's nothing to worry about. This is often what it looks like clinically. The main thing is you got to take a deep enough biopsy. And the second thing is make sure it doesn't get overcalled as a cancer. And it can. I've seen it overcalled as a malignancy before. Whenever something, you have to be a gatekeeper in dermatology as well. You should never take what the dermatopathologist says as gospel. If it makes sense, clinically it looks like an obvious basal cell, you shave it, it goes back as a basal cell, well, there's no reason to question that. But if you do a shave biopsy and it looks like a melanoma and it comes back as a basal cell, well, it might be a pigmented basal cell. That can explain everything. But if it doesn't make any sense, get on the phone and call the dermatopathologist. Don't just assume that it's right. There's an old saying, if you assume, you make an ass out of you and me. So don't assume anything. You want to make sure that that there's not a mistake. What if maybe there was a mix-up, either in the laboratory, maybe in your office? What if they looked at it and didn't recognize that there's a melanocytic input? So always, I love it when a clinician asks me a question about something. I don't think that they're being annoying or stupid or anything like that. Most of the time when they call me and they're worried about something, I say, well, the good news is everything fits here, no problems. But occasionally, we'll cut deepers, we'll go back and look at something, we'll look at the photograph. And boy, I love getting pictures with my cases. Send those, we work it out, say, well, the biopsy just doesn't really fit that well. I don't care what the biopsy shows. We're going to change the diagnosis to fit the clinical and the pathology, put it together, maybe take another biopsy and there's an obvious focus of melanoma. Maybe you cut deepers all the way through the block and there's a tiny focus of one in the original section. So you have to realize that this biopsy is not like, taking a blood test or taking a measurement like a survey where you've got those telescopes that those guys, are getting down to the millimeter, things like that. There's an art to this stuff, and part of being accurate is correlating with the histology, what we see clinically. So don't just assume everything is right. You have to always make sure it makes sense. Okay, now we've got a punch biopsy. And once again, notice that it's diffuse. If it was at a shave, we'd miss out. Shave would just be like looking at the first episode of Game of Thrones. You'd be very disappointed if you didn't get to watch the whole series and see how it ended up. So we need to see a punch to look at the whole thing. We've got a diffuse dermatitis once again. And here, we've got nodular areas of lymphocytes, we've got areas of histiocytes, and they're almost kind of forming a little ring. And they're also going down deep. So we've got a diffuse dermatitis that's almost layered, and it's forming these round little zones. And when we think of that, we think of the palisaded granulomatous dermatitis category. Now, the good news about that is that's a short differential. There's not a lot of things in there, but you have to have criteria to distinguish each of them from one another. Okay, so how do you do that? Well, first of all, what do we mean when we say palisaded? What does that actually mean? If we go back into the old days of the 1800s, when 1700s, whatever, when Fort Ticonderoga and Fort Phantom Hill outside of Abilene, where I grew up, they had these forts, And they would, just like if you ever saw the series F Troop, where they were living inside a fort, they have these sharp, telephone pole-like poles that they stick in the ground, and they got the gate that they open up, and when the Native Americans are running after the soldiers, they run in there, they close the doors, and then they're safe. Okay, so they refer to that as being palisaded. So that's a palisade of those spikes sticking around what's ever in the center of that. So it protects you. So we've got histiocytes that are forming these little palisades here. And these maybe are the Indians out here, and the soldiers are in here, and they're nice and safe now. But basically, you want to see what's in the center of the palisade to help to make the diagnosis. And there's usually, in the three classic palisaded granuloma dermatitis we think of granular annulare, necrobiosis lipoitic, and rheumatoid nodule. And just like anything else, that's the basics. When you kind of start looking at it a little more deeply, there can be exceptions to the rule. But basically, we look inside the palisade to see what is in there. And the other term that I'll throw out to you to remember, that helps you kind of remember this, is we were taught the concept back when I was a resident by Dr. Al Kopf, who was a luminary in our field a number of years ago, a giant of dermatology. He said that he was taught these were called the Thesaurus or Thesaurus voces. And what's a thesaurus? Well, if you look at the Greek word of thesaurus, it actually means treasure. And I think, thesaurus in the US, well, maybe it's been Latinized, but the TH was theta, so it actually originally came from the Greek, and it meant a treasure chest. So that's what a thesaurus is. It's a treasure chest of words. So if you're ever writing a paper or something and you want to get a synonym for a word, in the old days, you'd pull out your book and you flip to the page and you say, whatever word you're looking up, you look it up and say, this is a better word. I'll use this synonym for it. And I've already used the word 6 times. I want to use a new word. And that was like you're dipping into the treasure chest, and that word was like a piece of treasure that you were getting out of there. So this is like the treasure chest, and you want to see what's inside the treasure chest. And if it's degenerated collagen, like we have here, that favors the diagnosis of necrobiosis lipoitica. It doesn't mean it's necrobiosis lipoitica, because sometimes in granular annulare you can get some degenerated collagen, but it's not as common as in necrobiosis lipoitica. Sometimes in LD you can see some mucin. So again, these are not perfect, but it favors in LD when you get collagen in the center of the palisade, in the center of the treasure chest, if you will. And some other things that help you are if you see plasma cells. Plasma cells love degenerated collagen and sclerotic collagen. They go with it like ham and eggs. You always see it there. I personally think it's a pathologic process that's really related to it that no one's really figured out why, because it's always there. It's in morphia, it's in this, it's in any of those diseases. But it's always there, and that's a helpful clue. The other thing about NLD versus GA is that it tends to be kind of layered. It tends to be more top to bottom, side to side. It's kind of what we talk about, the layer cake pattern, like here, top, middle, all the way to the bottom side here. So that favors NLD also. So if you see fibrin in the center of the palisade, it favors rheumatoid nodule. If you see mucin, it favors GA. So those are the 3 main palisade granulomas. There are others. We'll talk about some of those later, but those are the major ones. And if you do a biopsy of an LD, which you usually don't need to do, this is what it looks like. So it's a nice example of an LD and a nice example of the differential diagnosis of the palisaded granulomatous dermatitis that are most commonly encountered in our specialty. Okay, we've got a couple more here we'll look at, and here we've got another biopsy. Again, I'm going to emphasize over and over and over and over again until you hear it in your sleep. I hope you have a dream and you wake up hearing my voice saying, never take a shave of an inflammatory skin disease, and hopefully you wake up in a cold sweat, or you wake up in a calm demeanor and say, well, I would never do that anyway, so I don't have to worry about Dr. Cockerell screaming at me. So anyway, you got a nice punch biopsy, and notice once again we're dealing with a paniculitis. So we've got two paniculitides today. We got two paniculitides and a fasciitis in one set of interesting slides. How about that? And if you did a shave biopsy on any of them, you're a wasteful person. You didn't help your patient one bit. But notice here, we've got a septal mostly paniculitis. Now again, I always like to say mostly because these things don't ever, not usually 100% septal. Even in morphia, which really involves the septa 99%, you get some periseptal lymphocytes and plasma cells there. So it's these are never 100%. They don't read the textbooks 100%, but it's mostly septal. We don't see any vasculitis. We see this inflammatory infiltrate again, which we're going to ask ourselves what kind of inflammatory cells are present. And we've got histiocytes. We've got some neutrophils. We might even have some eosinophils here. We've got some histiocytes over here. Some of them are actually a little bit foamy. And when you talk about the histiocytes kind of forming a little cluster of granulomatous inflammation right at the periphery of one of these little thickened septa, normally septa are like one fiber and collagen strand thick. This is really thickened here. This is markedly thickened up here. People talk about that as being Miescher's radial granuloma. Now, I don't use a lot of mnemonic names anymore in histologically, but I don't like Miescher's radial granuloma. Miescher, to honor him, he did lots of interesting things in our field, but it's basically just granulomatous inflammation at the periphery of the thickened septa and the lobules, and they can have multinucleated histiocytes. They can have some slightly epithelioid morphology, so you don't really need to do that. So the reason I don't like it is people look at it and say, well, is there Miescher's granuloma here or not? If it's not, it can't be erythema nodosum. Well, wrong. It can be. It depends on what stage of the evolution you're dealing with. If you see erythema nodosum really early, you may not get any granulomatous inflammation. If you see it late, most of it may go away. If you see it late, clinically, it can almost look like bruising. And in fact, the other name for that is erythema contusiformis. Looks like a bruise. So thickened septa, periseptal granulomatous inflammation, erythema nodosum. End of discussion. No, sometimes things are just so straightforward when you see that 2 + 2 = 4. It can't be anything else. So you might do a stain to rule out an infectious disease, but it's going to be negative. This is not erythema induratum. There's no vasculitis. There's minimal involvement of the lobules here. In erythema induratum, you get diffuse suppuration in the follicles coupled with some granulomatous inflammation, and then vasculitis. If you're lucky enough to get it in a specimen, and if you do a punch, you very well may miss that. You may have to actually take an incisional biopsy to get that. But still, this would not be erythema induratum. And notice that there's not too much inflammation going on in the overlying dermis. A little bit here, but it's relatively rare to get inflammation in the overlying dermis with erythema nodosum. And this is the classic clinical appearance of erythema nodosum. The tender nodules, usually pretibial areas, but can involve other parts of the body. We see erythema nodosum sometimes on the trunk, on the extremities. Excuse me. So it's not confined to this area. And then, of course, the important thing here, too, is that you don't miss other underlying diseases. So at a board examination, pretty straightforward histologic diagnosis. We may ask you questions right away about what these diseases are associated with the erythema nodosum. Underlying deep mycotic infections, coccidioidomycosis, things of that nature can be associated with erythema nodosum. Strep infections can be associated with a number of different conditions. So make sure that you know that. Make sure you know the histologic pattern of erythema nodosum, and make sure you understand the fact that you need to take a decent biopsy of all forms of paniculitis, or you're not likely to get any diagnosis at all. Okay, let's stop here for this morning. It's an hour's worth of information for you to digest. I hope it was valuable for you, and again, hope you've learned a few things here, and we'll keep hammering away at this stuff until you're expert at taking good biopsies and correlating clinical information with histopathology. Thanks again for listening, and we'll see you next time.